gives me great pleasure to introduce this year's J&J lecturer, Professor Vivian McAlister. Those of you who read my newsletter will know that Vivian has recently been awarded the Order of Canada, one of Canada's most prestigious civilian awards, for his seminal contributions and leadership in the military and civilian surgical communities as a medical practitioner, researcher, and educator. Vivian and I go back a long way. We grew up in the same neighbourhood, were classmates in medical school, and interns together at Sir Patrick Dun's Hospital. Following internship and basic surgical training, Vivian headed to Canada, where he did a fellowship in HPB and transplant surgery. He became a consultant in Halifax, Nova Scotia, and in time the lead transplant surgeon in the Canadian Maritime Provinces, before moving to London, Ontario, where he is now a professor of surgery at the University of Western Ontario. According to the Canadian Medical Association website, Vivian was enjoying a comfortable life as a transplant surgeon when in 2006, a presentation at Grand Rounds by a former medical student who had just returned from a tour with the Canadian Armed Forces in Afghanistan prompted him to volunteer as a civilian surgeon for the mission in Kandahar. I will leave Vivian to relate the rest of his story in his lecture, Kandahar to Canada.
President O'Connell, members of council, fellows, friends, thank you for the privilege of the Johnson & Johnson Charter Day lecture. Charter Day commemorates the incorporation of the college in 1784, but there are many charters documenting progress of surgery and of the college from 1446 all the way to 2019, when the college was granted independent university status. It is a privilege to be part of these celebrations. I have been asked to speak about my experience as a military surgeon. I will concentrate on the challenges that I thought I faced as a transplant surgeon asked to look after severely injured patients. We'll deal with catastrophe surgery, a program we call MASCAL, the interaction or the overlap between transplant and trauma. I'll talk about some of the situations where we had to improvise, and we'll deal with some of the ethical problems that arose during deployment. Catastrophe surgery is a concept that we developed actually before the wars in Afghanistan and Iraq. It was when a resident came to me as he was qualifying. He was a member of the Canadian Armed Forces, and he said he wanted to stay on to do a fellowship. We didn't think the military would be that interested in a transplant surgery, so we developed the concept of catastrophe surgery. And it is the surgery required to treat an individual patient with devastating injuries or care for multiple casualties simultaneously. I was first deployed in 2007 to the multinational medical unit at Kandahar Airfield under the command of the Canadian Armed Forces. I was a civilian augmentee, and many of the doctors there were members of the armed forces of the Allied nations. What I found was a very smooth team that was capable of looking after very badly injured patients and multiple patients at the same time. I discovered that the reason for this expertise was the fact that they practiced incessantly and each knew what job to fill in time of emergency instinctively. This is a picture of wounded being evacuated from a beach, and it's taken at the time of the Dieppe raid in 1942. But you will notice that the soldiers are not under any duress, and they're certainly not under fire. And the reason is that this is practicing for that event. And here is a picture of some of the casualties that they did evacuate from the Dieppe raid in 1942. Similarly, this picture is often thought to depict a casualty being evacuated to a helicopter in Afghanistan. But in actual fact, it was an exercise practicing evacuation that we undertook in Alberta before deploying. The Canadian Armed Forces exercises with full-scale method using the equipment that they will deploy with. And you will see that this tent, which is actually in a rack, is very similar to the exercise tent. And you will also notice that the surgeon and indeed also the anesthetist stand back while the first responders undertake ATLS with the patient. So we wrote a paper to say drills and exercises were a very useful way to rehearse and to be expert for these rare events, such as a mass casualty incident. Drills are things that come naturally to you in an emergency, and in surgery you'll be thinking of ATLS or indeed damage control surgery. Exercises are when you put teams that are working together in complex movements, and a hospital would be the equivalent to that in the military. MassCal was a training program that we developed to try and meet these goals. I attended the Canadian Surgery Forum regularly, and I was asked to develop programs where we could use lessons learned in Afghanistan in civilian surgery. I offered to undertake a full-scale training for a mass casualty incident to train civilian hospitals, and this offer was eagerly taken up. I had hoped we could deploy a military hospital beside the convention center, but unfortunately that hospital was taken elsewhere at the last moment for a more urgent need. So we had to improvise. So instead of having a full-scale exercise, we actually improvised a no-tech, but we hoped high-fidelity approach to that training. I had a good cadre of medical students who played the patients, and instead of making them up with casualties, we just described their injuries and hung them by cards around their neck. The students took part in the debrief, and they were not only able to learn about the process, but they also contributed the perspective of a patient, and it was very well received. Indeed, we did not have any equipment, and we used chairs and room dividers to make things like trauma bays shown here. And one of the interesting things I learned from the participants was that their imaginations were able to develop scenarios in a much more realistic fashion in their mind than anything we could have done artificially. We developed that program as a manual that others could use, and we have adapted it recently for remote delivery, given the times that we are in. Hopefully, we will have a template from it for online scenario-based team training. I was able to use the experience of these field hospitals to advise our local hospital regarding COVID-19, and we set up a field hospital for COVID-19 in the Agriplex in London. The Agriplex is very similar to the RDS, and the dividers here are actually horse stalls. Change gears here a little bit and go to surgery itself. As a liver transplant surgeon, I was expected to be pretty facile with liver injuries. The first patient I dealt with on the first deployment was a young boy of 9 who had had a secondary hemorrhage 3 weeks after multiple surgeries for abdominal and chest injuries from a gunshot. I was very concerned because the boy was very fragile, but fortunately a CT scan that we were able to do in that small hospital showed an arterial bleed, and ligation of the right hepatic artery was sufficient to control the hemorrhage. In dealing with liver injuries, I usually stand on the left of the table. I hold the fragments of the liver together to try and stop the hemorrhage, while my associate packs around the liver, always mindful of the fact that I have to remove those packs at a later date. This is a picture of the actual operation. The military photographer was present, and I'm standing on the left. My assistant here is orthopedic surgeon David Puskas, and that was the typical way we deployed: one orthopedic surgeon and one general surgeon, and we were able to deal with most surgical requirements. The disrupted pelvis is a highly feared injury causing a lot of hemorrhage. It's seen in the civilian world, of course, with high force injuries such as road traffic accidents. We saw it with the improvised explosive device, where the force comes up from the ground, causes amputation of the legs, and splits the pelvis. There is a lot of hemorrhage that's difficult to control. And here I've packed the perineum with combat gauze, which has radiopaque marker in it. We've applied an external fixator, but it hasn't reduced the pelvis. We reduced the pelvis, but the bleeding continued. Therefore, I determined to ligate the internal iliac using an extraperitoneal approach. Fortunately, I was familiar with that from kidney transplantation, and once we had it done, the bleeding stopped in this particular case. Organ donor surgery provides a great opportunity for trauma surgeons to learn maneuvers that are required for seriously injured patients. Teams working simultaneously requires cooperation. There's a limited time for both types of surgery. Sternotomy can improve abdominal exposure, and a donor surgeon is very facile with sternotomies. The maneuvers to expose the viscera are all done in organ donor surgery, and control of the aorta and vena cava is necessary immediately upon entering in donor surgery and very useful in trauma surgery. Finally, some of the exposures that are required, such as exposing the carotid artery, can be used to retrieve vessels for grafts and transplant surgery, and at the same time train the trauma surgeon. Recipient surgery is traditionally thought as the place where a trauma surgeon can learn most. And it's true, they will learn how to undertake anastomoses between arteries and between veins. And this has become more necessary recently because endovascular surgery has reduced the opportunity to train and maintain these skills. Indeed, general surgeons are now asked to undertake emergency vascular surgery for catastrophic vascular events, whether they're traumatic or not. And this type of training will be useful to them as well. Damage control vascular surgery is becoming an area that needs to be developed further and the principles promulgated among the community. We're going to change tack once more. This is the hospital that we deployed in Haiti. I just want to talk about some of the need to improvise. Sometimes you're asked to do things that you are not, that you don't do back at home. After the traumas were looked after in Haiti, the commonest surgeries that I did were hysterectomy and surgery for hydroceles. In fact, I was able to report that hydroceles in this population are probably not from filariasis, but most likely from a patent processus vaginalis that has been neglected for the life of the patient. This young boy was brought to us with gangrene of his leg. He had bleeding from the femoral artery, and a previous surgeon had ligated it to control the hemorrhage. Unfortunately, he developed gangrene and septic shock. We performed an amputation and reversed the shock, but acute renal failure was a death sentence for patients in Afghanistan, as this boy is. This because there is no availability of dialysis. Fortunately, I was familiar with peritoneal dialysis because of the patient population for kidney transplantation, and we improvised peritoneal dialysis for this boy. We used drains as catheters. We used 5% dextrose modified according to these recipes as dialysate, and I modified dwell times and exchanges to achieve dialysis. Fortunately, the boy recovered, And our program for improvised dialysis was incorporated into the Joint Trauma System Clinical Practice Guideline, as outlined here. For those of you who are doing trauma, if you Google JTS CPG, you will find these guidelines very useful at home as well as in deployed settings. Now, this young boy had multiple surgeries of the abdomen for a gunshot wound. And while the intestine continuity was restored and his abdomen was closed, we were unable to feed him. Even trickle feeds were rejected. He was wasting away, and we thought we'd have to use TPN, which we started. Unfortunately, he continued to deteriorate. His father stayed by his side, as many fathers did in Afghanistan, and these pictures were recorded by a war artist, Richard Johnson, of the National Post in Canada. A visiting surgeon came by and said to us, "You can't use adult TPN in children." I had not known this, but fortunately we were able to improvise pediatric TPN by adding dextrose and other elements that were available. The boy immediately started to recover, and after about 2 weeks treatment, he was back to using ordinary feed and was able to be discharged. Evisceration is a commonly seen problem with gunshot wounds and blast injuries. I would ask that the intestine not be reduced, because there were always perforations associated with it. And indeed, when I got to surgery, I would deliver more bowel and place it in a basin and wash it with saline to get rid of all of the muck and debris, close the holes, and then conduct the laparotomy. This type of injury always leaves a big hole in the side of the abdomen, and we were able to use peritoneal flaps to close it from the inside on the first operation, and use musculocutaneous rotation flaps to close the hole on the outside at subsequent surgeries. Damage control laparotomy is a great development in trauma, to have rapid surgery to allow the patient to recover and then undergo definitive repair. Ken Maddox, who described it in the book Top Knife that we all use, described using blind end resections. I was always nervous about getting back and finding edematous bowel that would be difficult to anastomose, or even worse, not being able to go back at all. I preferred to do a resection anastomosis, again with 2 firings of the stapler, to achieve the same end. And then I could check the anastomosis at the second or subsequent operations. A vacuum dressing is the commonest temporary closure that was used over there. I never liked it. It was difficult to transfer patients with it. And I found that a skin-only closure was adequate in most cases. I rarely saw abdominal compartment syndrome, and these patients were easy to manage on the ward. Eventually, the fascia was closed at the last operation, and it was easier if you had done a skin only than if you had kept them apart with a vacuum dressing. The first picture I showed you of a tent, you saw how dusty it was, so it's a difficult place to carry out surgery. So we, in the last deployment, made a mobile operating room out of a housing unit on the back of a military vehicle. And we drove that thing all around Iraq. You can see we covered it with camouflage here. Inside, it gives a good operating room, and we operate on stretchers. But stretchers are difficult for surgeons. It's hard to operate on anything other than the center of the abdomen. It's hard to put the patient's arms out. So we made a mattress that fit into the stretcher with onboards, and this converted the stretcher into a very good operating table. The housing unit itself was absolutely hopeless in conflict situations. It wouldn't stop any missile or bullet. So we developed specifications when we got home for a mobile operating unit and sent it to the manufacturers to be useful for far forward surgery, which we think may well be the military surgery of the future. Now, 2 ethical things. Suicide bombing causes terrible injuries, emotionally as well as physically. Suicide bombing is indeed the final heresy. For the surgeon, not only do you have to look after the trauma, but you must also be mindful of forensic documentation, preserve evidence with a chain of custody, find suspect tissue and for identification, but especially of its viral status. And in this paper here, we developed protocols for post-exposure prophylaxis of victims. And lastly, the improvised explosive device that I mentioned earlier, and I showed you how it disrupted the pelvis, was a weapon that we found to cause horrific injuries. So we therefore undertook a prospective cohort study, and we compared it to the injuries seen with landmines. We used the same definition of the target of the weapon as the person who had a traumatic amputation. But we found that our patients had multiple amputations more often than a single amputation. And the weapon is just as indiscriminate as landmines, affecting young children as well as older adults. Therefore, in our report, we included the phrase that this weapon was designed to cause superfluous injury and unnecessary suffering. This wording is chosen carefully. It is in the Geneva Convention, and those who use the weapon with this intent have committed war crimes. Well, I hope I've convinced you that there is considerable opportunities for trauma surgeons to learn on the transplant service, and I was very fortunate to have that expertise when I was faced with these situations. The simultaneous team surgery, rapid decisive surgery occurs in both situations. Significant resuscitative support is required for trauma and transplant patients, giving you opportunities to train for anesthesia and critical care. The surgery of exposure, vascular control, repair, anastomosis, and pelvic surgery, the techniques are all available in transplant surgery. And finally, both areas deal with ethical challenges. I have a lot of people to thank for the training that they gave me and the mentorship. And they are outlined here, and there may be others that I have not included. I'm very grateful for their expertise, and it's because of them that I was able to meet the challenge that I was so afraid of at the beginning. I will highlight that Niall O'Higgins put me on the path of liver surgery and facilitated my transfer to London, Ontario, where Bill Wall and David Grant trained me in transplant surgery. Gurab Mila Mahagiv Galer. Thank you for the privilege of this lecture. I hope that I will be with you in person before too long.
Vivian, I was most taken by your quotation on the Canadian Medical Association website. It changes the morale of our fighting men and women to know we're going to be there and that if needed, we will bring them home in the best condition possible. May I congratulate you on your exemplary service to your community and to your adopted country. Thank you for your profoundly moving lecture. I would like to close by acknowledging the support of Johnson & Johnson towards RCSI and surgical education and training in Ireland.